fluorescence, and also if you closely observe, those changes were present in the color fundus photograph also. So most of these changes are mistaken for myopic changes most of the time. So, and these patients also get misdiagnosed as rod cone dystrophy. So because ERG in this patient, if you see, like, there's a very mild derangement of dark adopted 01 and 30 ERG, but some patients can have like gross derangement in both dark adopted and light adopted responses. So basically, she's a carrier of RPGR mutation. Can go to the next slide, Samiksha. So the father had a mutation in a gene called RPGR. Next. So, so basically, what happens in case of this X-linked retinitis pigmentosa? Usually, the males are affected, and females will be most of the time they'll be carriers. And because of there is some process called lionization, which is a rapid deactivation of X chromosome, which happens. They will have this background RP changes. So those are my comments. So maybe others can also comment if they have similar experience. So they later I can comment on how to go about the genetic testing, what panel and all.
Right. Dr. Neha, your comments on the case?
So very nice case, Dr. Samiksha. Thank you for sharing, and Dr. Purna also. So finally, your diagnosis becomes a X-linked carrier of X-linked recessive RP.
Yes, yes.
Right. So, well, I would, to be very honest, clinically go more by the clinical picture where, it's, I mean, for me, the first slide was kind of a giveaway that it's a young girl and the father has a history of night vision problem. So, yes, of course, we would like to do all the imaging of the girl child, that is the primary in this case, but examining the father, again, the father has a very typical picture of retinitis pigmentosa. So that would again narrow it down to and since only the daughter has the features, not the son. So, I mean, we need to do genetic testing, but even without that, we can assume it is one of the X-linked recessive RPs and the daughter is a carrier. So going by that clinically, I think it's quite straightforward. And yes, the autofluorescence changes are much more marked than the color fundus picture. OCT, as we know, there is central sparing in RP anyways till late cases. So that goes in conjunction as well. But I think it's good that the genetic testing has been done, which maybe Dr. Purna can tell us more about, and what the implications of that would be.
Yeah, so the reason being, as we know, like all recessive RPs are most severe, and in X-linked recessive are the most severest form. If you can see the father, he has got almost like macula is gone, his hand movements vision. So here the reason, like, parents were very much concerned because elsewhere it was diagnosed as a rod cone dystrophy, and I do get a lot of cases of these carriers who get misdiagnosed as rod cone dystrophy and all. So first thing is it will confirm the diagnosis, because I have seen few variants of very early rod cone dystrophy with similar changes, and they want to have some pathogenic mutation in very young children, like 4 years, 5 years, and all that. So for that reason, I got the genetic testing done. Of course, we need to
But
counsel the
you said, what about her color vision? I'm sorry to interrupt.
color vision was normal. Color vision
was normal.
Yes,
So
yes,
that
absolutely.
can again give us a clinical hint, I think.
Yes, yes.
Away
Even
from rod cone dystrophy.
no, rod cone in early stage, some of the forms it can be normal. So especially the children who are like 4 years, 5 years, and all that. Up to 12 years, I have seen, like, I mean, patients having like identifying all the plates on HKR. So of course, variations can be there. So that is one point. The thing is, it's one of the most severest form of RP. And the thing comes when a daughter being a carrier, so when she plans her whatever the marriage and all that, there are 50% chances of if she has a male child getting affected. So that we need to reiterate the fact for the prenatal testing and things like that. So I'll show just one more cases about how this RPGR associated dystrophies progress. So like, like X-linked recessive almost constitute for 20% of the retinitis pigmentosa. Among that, 90% of them will be caused by this RPGR. And RPGR is one such gene which is very large. Actually, it's very difficult to sequence. If you don't speak to your genetist, then most of the time in a dystrophy panel they will miss it. Even in whole exome also there are chances they might miss it. So even in this case, we have to at least be sequenced up to 95%, if not for 100%, to be very sure to label it as RPGR. So Samiksha, next slide. So this was a 28-year-old female who was diagnosed elsewhere as retinal dystrophy, came to us for second opinion. Next slide. So again, she was very high myop. I think it's around -9 diopter. So the background changes, it was like more or less like a myopic fundus, not that kind of a carrier. So next slide. So this is autofluorescence, which shows more marked background RP changes, which is typical of a carrier of an X-linked mutation. Next slide. So OCT, more or less macular, all the photoreceptor layers were very well preserved. Next slide. So again, these are the ERGs which gives, confuses one. Like if you can see this dark adapted and the both light adapted, this is grossly reduced, which can very well again happen in high myopias also. I have seen patients with no mutations having this reduced both scotopic and photopic components. Next slide. So this was her pedigree. She has a father who is 55-year-old who is affected, and she was been labeled as affected, and she has a 3-year-old son. Next slide. So this is the father. So if you could look at his fundus, so hardly had vision of 1/60 in both the eyes. You can see the sectoral distribution of pigmentary changes with macular involvement. So the macular involvement relatively happens early compared to any other forms of RP. That's why it is one of the severest form. Next slide. So this is his OCT showing extensive atrophic changes. Next slide. Autofluorescence of the same patient, the father. And next time, next. So this is the son. He's I think 3-year-old. Again high myope. His vision is 6/12 as of now. Doesn't have any complaints. Next slide. OCT is pretty okay. Next slide. So look at the autofluorescence pattern. Except for the macula, there is already the changes. Almost it's resembling his grandfather. I think we have summarized all three in the next slide. You can go to this. So this is the proband, the 28-year-old female who presented to us, who was found to be a carrier. So next. So and just look at the father and the son. So the son who is 3-year-old is pretty normal. I mean, yes, the myopia of I think -10 or -12 with a pretty normal vision. But if you look at the autofluorescence pattern, it's almost resembling the grandfather. So eventually, it's most likely it will progress. So this is in summary, like, and proband, she doesn't have anything. She's just a carrier. I mean, she will not have any progression of, she will not develop any atrophic or degenerative changes in the near future. So when we did the whole exome sequencing, and then there was some confusion. We got 3 mutations. One is in ROM1, RPGR, and ZNF. That ZNF408 it was of uncertain significance. So ROM1 can also cause retinitis pigmentosa, but if you look at the clinical features, the carrier state of the, female, the how only males are getting affected, the severity, this is more in favor of an RPGR mutation. So hope I
Dr. Purna,
take a lot of time. Yes, please.
actually, I wanted to know where can we get this genetic testing? From where did you do?
Yeah, we usually send our all samples to MedGenome. Yeah.
They have their office in Bangalore, no?
Yes. It's their office is in Narayan Nethralaya only, their main branch. So they're just across. That makes us easy to discuss clinical scenarios also.
Yes, but I think it's good you brought that up because they're very cooperative and willing to pick up samples almost pan-India.
Yes.
And their rates also quite reasonable. In fact, in Delhi also, Gangaram has also outsourced their genetic testing to MedGenome now, which we used to get done earlier. But it's not an issue. I mean, they arrange for the pickup and the transfer of the samples. And it takes around 1 month for the report to come. The only difficult, rather not difficult, I would say the only challenge is to convince most of the patients, to be very honest.
Yes.
what I feel. Even though they are cooperative, they bring down the price from around 16 to 18 to around 13,000. But it is just the whole question of, I mean, there will be some who will come to you for it, that, you know, it runs in the family, tell us, etc. But if it's a first time diagnosis, at least I find it challenging to convince a patient to get it done, when I cannot, offer any therapy based on this test. So I would like to know
Yes.
the others' experience, how it is.
No, that's a very important point, I think, what you brought out, Dr. Neha. I think counseling, I think we have a separate session for counseling session. Whenever we subject any patient for a genetic testing, it will be for 45 minutes. Have to make them very clear what we are going to do, because in Indian scenario, the moment they spend so much of money,
Yeah.
they'll be an under impression that we are going to offer something to them. So of course, when if they come for prenatal testing, family planning, things becomes easy. It's
Yeah.
easy to counsel. But children's parents are very keen on doing anything, and for them, 25,000 is nothing. Okay, we can spend what can. So counseling is very important, and what panel you choose, that also becomes important. Like for example, as Dr. Neha pointed out, clinically where things are very clear, we can just go for the retinal dystrophy panel, so which is slightly cheaper. In case if you're not very sure of the diagnosis, then what you can do is you can go for the validation by testing the parents or the sibling. So even then, if you're not conclusive, then you can go for the whole exome sequencing. This is how the order what I follow. So very rarely I go for direct whole exome sequencing.
Right. So while we are on the topic of genetic testing, Dr. Kaushik, if you have any points to add on how do you counsel your patients for genetic testing and what are your criteria when you set your patients for testing, especially in cases where, like in this patient, we still had an idea because the father had RP, but in cases where you do not have a definitive history, then what would be your indications for genetic testing? Dr. Kaushik?
Actually, the in status of most of my patients do not allow to get the genetic testing, because this is like, I do this only if I plan to publish, and that is to with my own money. Actually, published on case with maternally inherited diabetes and deafness. They had a kind of pattern dystrophy in daughter and her mother. We published that, and we got the this genetic testing of MLTT gene from this thing made genome, but that was with our own money. But most of the our patients are not convinced and will not get the test done. Well, their financial status do not allow that actually.
So one more method what you can use is, Samisha, you can go back to the previous slide. Uh, the previous one. Yes, next one. The images. Yeah, summary. Like this, when you sit with them with the images, compare them and then explain them, these are the course, there's probability. And when you tell them there, by doing a genetic testing to an extent, we can prognosticate also. So that especially in children's, how they plan their career, the lifestyle, everything depends on what we counsel them, because there are few stationary dystrophies also. So like that, if we tell most of the time, they will do get convinced. This is apart from people who come for the prenatal testing, of course.
So just
Yeah.
changing gears a little bit, Dr.
Yes.
Neha, like especially in cases where, like this case where she was a carrier, what is the role of other investigations, especially HVF, in patients like this? Because we can see that the ERG changes are not very much. So is HVF going to reveal anything extra for us?
So for such a young child, I think less than 9 years, to be very honest, I wouldn't, because you see, to a large extent, the field changes and the ERG changes would go hand in hand. So I would definitely, I mean, if a child with night vision problems and family history of night vision problems comes to me, the first thing I will do is ERG, full field ERG, as has been done. and apart from, of course, color vision and all of that. And that would narrow down the diagnosis pretty straightforward at this stage. But yes, I'm not sure at what age, but definitely in the adults, I would like to do visual field testing and also repeat it yearly if the results come, in a way that is repeatable. That means if already the ring scotomas and all have not formed. I also, in cases of advanced RP, who still, sometimes have good vision 6/9, 6/12, I like to do multifocal ERGs to follow them up. So if it is a clear-cut case of RP, to be honest, walks in my OPD, I would order a field test for medical-legal purposes in case he's driving and all that, and a multifocal ERG, not a full field ERG, because short of genetic testing, multifocal ERG also does, to some extent tell you the prognosis, or you can reassure the patient based on that.
Right. So, Dr. Kaushik, I have another question for you. Like the patient's age is 9 years old, and in such a young patient, especially with features of RP, they can be associated with a lot of syndromes as well. So, what do you think is the importance or the role of systemic investigations in these patients?
Just I would examine the family members and ask for any especially look for extra fingers or toes in Bardet syndrome, and also if there is a say difficulty in the balance. Most of the time, all
Not
in
able
skin.
to hear.
Most of the time, the diagnosis.
We are not able to
Hello,
hear you properly.
am I audible?
Yes, now it's better.
Hello, am I
Maybe if
audible?
you shut
Hello.
off your video, it will become better.
Okay. I think the most of the time syndromic RPs are quite obvious. They'll I have actually in most I had seen one case of Bardet-Biedl syndrome. Actually, the characteristic feature is that they'll have extra fingers, and both in extra finger in hand, extra toes, and also they the child I saw, he had like height was less, and there was obesity. And also another thing is you have to rule out USAR also. You have to actually in OPD we'll have to ask for any systemic problems which he has, or if there is any obvious disease, obvious morphological changes which is visible. Uh, and
I think we've lost him somehow. Maybe Dr. Purna, your comments on what is your approach to systemic investigations or systemic examination in these patients?
Yeah, that's a very good question. Actually, I keep, stressing on the fact, even to our fellows and all that, whenever you examine the dystrophies, never take it in isolation. Some of them can have syndromic association. Some may have obvious manifestations, some may not have. So the obvious thing, I think Dr. Kaushik already, he described like Bardet-Biedl syndrome, Mosher syndrome, Kearns-Sayre syndrome with external ophthalmoplegia and all that. So one thing what I would like to reiterate here is when you see an RP, OCT resembles a pattern of RP, like for example, parafoveal photoreceptor. And if you don't see any obvious pigmentary changes which are similar to RP, like bone speckle pigmentation, which are like kind of atypical appearance, then suspect syndromic association. And polydactyly sometimes may not be present because some parents, they get the sixth finger, they get it amputated because of cosmetic reasons and all that. So that is one thing. And when you have to be careful when you suspect this metabolic pathies like Alport syndrome, Aicardi syndrome, axalosis, cystinosis, these are the cases in which you have to be a bit extra careful. So coming back to your question, so always whenever you diagnose a dystrophy of any undergoing any systemic surgery, patients may not feel it's relevant, but you need to extract that history. So that is my take on the. I have to do a thorough systemic evaluation. In case if you're not sure of the same, refer it to a pediatric neurologist or a pediatrician who can help you in that.
Right. So that is a very important takeaway from this discussion, I guess. That leading
Dr.
question.
Punna, I wanted to ask Dr. Punna, like,
Yes, yes.
which patients do you send for pediatric evaluation in patients with RP? Like, do every patient require this thing, or
No, no, not
uh,
every patient,
that,
not every patient. Yeah.
mm,
So
like when do you?
so first thing, if I have to repeat my points, when the RP, my dystrophy is not very typical. If you observe carefully, this Usher syndrome and Bardet-Biedl syndrome RP, they're a bit more aggressive and they have a different pattern of RP. By looking at that only, you can diagnose those scenarios. And the second scenario is where I'm seeing obvious external dysformism like dysmorphic face, hypognathism, or maybe excavatum chest, or any limb abnormality, skin elasticity, skin pigmentation, or hair color depigmentation, anything unusual you see on an appearance. These cases I'll be more inclined to the refer to the patient. Of course, simplex cases where everything looks normal, at least to you clinically, and you have a classic dystrophies which you can label with a term like RP, Stargardt's, whatever, I don't prefer.
Thank
And
you.
also, the third thing scenario is when I get the mutation. When I get the genetic report, if the genetic gene mutation suggests that this gene mutation is likely to have, for example, if I get a gene which is more associated with the ciliary function, so if the patient may be appearing normally, in those cases, I refer.
Thank you.
Right. So, in the interest of time, I guess we'll have to move on to our next case.
Can I just make one point, Dr. Komal?
Yeah.
That in the absence of family history in a 9-year-old girl with night blindness, we must think of vitamin A deficiency also, because that's easily reversible. And ERG is a very good test which will easily differentiate between the two. So family history and full field ERG should definitely be done. So ERG will give you a negative waveform in addition to a reduced rod response, and some of the cones will also be reduced, which you will not get in RP or a carrier of RP.
Right. I guess that's a very important point, a very important takeaway again. So we'll move on to our next case, and this is by Dr. Piyush Kohli, who's a medical consultant at Arvind Eye Hospital. Dr. Piyush, you can please go ahead with your case.
Good evening, everyone. First of all, I would like to thank UC Late Night Retina to give me this opportunity to present this case. I'll be presenting multimodal imaging in enhanced S-cone syndrome. So an 18-year-old male presented with bilateral progressive gradual painless defective vision. It was associated with night blindness. There was no history of ocular trauma or any chronic drug intake. There was no significant family history. So his uncorrected visual acuity in right eye was 6/16 and left eye was 6/36, getting corrected to 6/24 in right eye and 6/12 in left eye. Refraction was hyperopic with thus 1.5 in right eye and plus 0.5 in left eye. Visual axis is parallel. We did central visual field only, that was normal. Anterior segment examination was normal only. The posterior segment examination, the media was clear. A cup disc ratio of 0.3 with a healthy NRR. The vessels were caliber was normal, and there was nominal pigmentation around the vascular arcade with the cystoid macular edema. The picture was similar in the left eye also. Fundus autofluorescence, there was a large hypoautofluorescent ring with a central hyperautofluorescent center. It was similar in the left eye also. OCT showed retinoschisis, macular retinoschisis in right eye, and similarly in left eye also. So ERG, it was practically absent in DA 0.001 ERG, and in other also, it was the amplitude was reduced and latency was increased. This is for the other eye. So this is a normal S-cone ERG in which L and M, which form the major chunk of the cones, are more and less is the S. In the contrary, S-cone ERG of our patient, there is a supernormal response of S-cones. So a bit of discussion. It is an autosomal recessive disease with a mutation in NR2E, which is expressed in outer nuclear layer. In presence of cone rod homeobox protein CRX, NR2E binds to opsin and promote transcription of rhodopsin and suppress cone opsin. In the absence of NR2E3, the immature rods either lump into S cone or degenerate. This leads to the classic CS fundus morphology, that is the region along and just outside the arcades, which have normally the greatest density of rods, are most susceptible. The major differential is JXLR, that is the juvenile X-linked retinoschisis. The major differences are vitreous degeneration is absent, peripheral retinoschisis is absent, cataract is absent, and EOG is normal for enhanced cone. The limitation of what we did, we missed a pedigree chart. We did not do a EOG. Visual fields are lacking, and we did not do a genetic testing also. So my question for the panelist will be the other differentials for the case and ERG findings, use of S-cone ERG, role of genetic testing, especially for prognosticating, and typical ERG findings for retinal dystrophy, mostly three. One is cone dystrophy with supernormal rod ERG, second is the enhanced S-cone, and third is the bradopsia. Thank you.
Thank you, Dr. Piyush. So we'll just go ahead with the first question that you have put up with a bilateral symmetrical picture like this. Maybe Dr. Kaushik, you can take this. What are the differentials that you would consider on seeing a fundus like that?
I would consider retinitis pigmentosa as a differential, and also in retinocytes will be another differential. Congenital stress eye blindness with such RP changes in peripheral area is unlikely, but obviously albus punctatus can also be kept in mind. But considering there is a foveal size in OCT and typical nummular pigmentation in this thing, and also ERG is showing enhanced taste response, the diagnosis is goes towards thing. Enhanced response, and also in RP pigmentation are typically like Chinese data, not numerous, and also arterial attenuation in this case was not so much as seen retinitis pigmentosa.
Dr. Neha.
And I'll
yes, Dr. Kaushik, please go ahead.
I'll ask Dr. Neha because he has experience in years to discuss about the year findings.
Yeah, Dr. Neha, so your comments on the differentials first and then the use of ERG, especially the S-cone ERG and its indications.
First of all, Dr. Piyush, congratulations. I think you're very lucky to see such a typical case of enhanced S-cone syndrome. I mean, yes, it's unfortunate for the patient, but my day would certainly be made if I see a patient like this in my OPD, because it's quite a textbook picture in most aspects, and a very nice presentation by you as well. Yes, I agree with Dr. Kaushik. RP would definitely be a differential whenever you see a pigmentary dystrophy with the history of night blindness. But then the OCT in this case kind of shifts your gear towards, XLRS, which is the second differential that would come. Yes, I agree. CSNB would not be really a differential here because you wouldn't see a fundus picture like that. So RP and maybe XLRS. I'm sorry, I don't agree with some of the points you put down for XLRS. Can you just go back to that slide?
I'll go back.
For X-linked retinoschisis. Yeah. So yes, vitreous degeneration, it is a vitreoretinopathy XLRS, that is true. But peripheral retinoschisis can be absent in up to 20% patients of XLRS also. X-linked recessive, they can have only the cartwheel appearance, 20% patients. Cataract, I would say, is really a feature which comes later. So, and EOG is normal. So let's go to the ERG findings now. First, X-linked retinoschisis, you will get a negative ERG over there, right? Because the problem is in the bipolar cell pathway. So you will get a negative ERG, which means in the combined rod cone response, your A wave is normal, which is the first negative, but your B wave gets reduced. So it's a typical negative ERG, right? EOG, yes, will be normal, but that will be there in enhanced S-cone also. Now coming to the ERG findings of enhanced S-cone. Now you really don't need an S-cone ERG to diagnose enhanced S-cone syndrome. And this is one of, I think, the favorite things that Dr. Jalali always says in all her talks. Just looking at the ERG, you can know that this is ESCS. So what happens if you go back to your ERG? So what happens is, first of all, you have a decrease. So if you look into ESCS, what happens basically, the rods are less and the cones, except the S cones, are also less. So if you know that fundamental, you will understand the ERG findings. There's a decreased rod response, okay, which is your, yes, dark adapted 0.01. This is decreased, okay. Now when you go to the combined rod response, so what will happen, the photopic and scotopic responses look the same, okay. That is classical of Goldman-Favre or enhanced S-cone. And if that happens, you don't even need an S-cone ERG to prove your diagnosis. And of course, because the cones are affected, your 30 hertz flicker will be reduced and delayed. Okay, so based on these three features, only you can diagnose enhanced S-cone syndrome. The problem with the S-cone ERG is that even normally it's a very small wave. So sometimes you may not be able to pick up. Another thing I'd like to point is that you sometimes get two peaks in the S-cone ERG. So then you have to see the second peak, because the first peak comes from the L and the M cones. Okay. So that is about ERG in enhanced S-cone. Based on 3 points, you can diagnose it just on ERG. You don't even need a S-cone ERG for that. The other situation in which I sometimes order S-cone ERG is your rod monochromatism. That is the color deficiency in which only the S cones are left and the L and M get affected. So rod monochromatism or S cone monochromatism, those are the ones in which, in color deficiencies basically, but that also you get ample clinical hints because this is X-linked recessive. So as opposed to the other one, which is autosomal recessive. So that can also give you a hint. Apart from that, I usually don't do S-cone ERG. And like I said, a very good waveform is difficult to get even with a trained technician.
Right. Thank you, Dr. Neha.
Thank you, ma'am.
Some very, very excellent. I'll also just ask Dr. Purna for his comments on the ERG findings in enhanced S-cone and the uses of S-cone ERG.
Yeah, so I think that Maya has already nicely briefed about these things. The few things maybe I can add. So, like you can go back to the ERG thing, waveform.
Piyush?
Yes, ma'am.
ERG, the fulfilled ERG.
Computer is a bit slow.
Okay, no problem. At least you can stop sharing. Otherwise, I can just show you. Yeah, hope all of you can see me. Like enhanced S-cone syndrome, it becomes easy to understand. Of course, what Dr. Piyush presented, as Neha rightly said, it's a very classic case. I mean, the moment you look at the periarcadal pigmentary changes with CME, like you need not even do ERG. Of course, you should do an ERG because there are only two scenarios in this thing, dystrophies, where even without genetic testing, the ERG can be a confirmatory test. One is enhanced S-cone syndrome and other is KCNV2 mutation, where you get a supernormal rod response with a cone dystrophy. That is one thing. So in enhanced S-cone syndrome, what happens in embryologically when there are two limbs of photoreceptors develops, one limb is supposed to form L and M cone. One limb is supposed to form these S cones and the rods. So because of this NR2E mutation, what happens is all the rods get replaced by these small cones. So that's why when you do an ERG in 0.01, there are no rods. It's only predominated by short wavelength cones. That's why you get an unrecordable 0.01 ERG. And if you look at this dark adapted 30 ERG, one specific feature which I think Professor Gramholder always used to teach me when I was in more fields, the broadening of A wave trough. So this is quite typical for this enhanced S-cone syndrome. So this is quite specific. And the second thing is, If you compare the dark adapted, of course, this was not there in this particular case, but in most of the enhanced discount syndrome, the dark adapted 30 ERG will be similar to the light adapted 30 ERG. Both will more or less look similar. So this is the second point. One is the broadening of A wave trough. The second thing is similar looking 30 ERG and a photopic 30 ARG. And the third thing is, if you look at the A wave amplitude in the combined response or maximal combined response, the flicker amplitude will be less than this A wave amplitude. So if you just observe these 3 points, you don't require an SCON ERG at all to diagnose. The clinical features and these ERG features will 99% of the time, it will clinch the diagnosis. So that is the regarding the ERG part of it. If you are in doubt, of course, you can do an enhanced discount protocol. May not be required, as Dr. Neha rightly said. So differential diagnosis may not be in this case, it's classical because enhanced discount syndrome can present as a spectrum. It can have absolutely normal looking fundus, but when you do an autofluorescence, there can be subtle variations in the autofluorescence of posterior pole, and it can range for RP-like picture also. So first thing is, how do you differentiate it from an RP? See, in most of the enhanced discount syndromes, you don't see arterial attenuation or a waxy disc-pallor. But in RP, invariably, the vascular attenuation and waxy dispeller will be present. The reason being, these pigmentary deposits happens in the RPE layer. There are no intraretinal pigmentary deposits as happens in retinitis pigmentosa. So that is one thing which is specific for enhanced discount syndrome. So other thing which you can get confused in at some stage of enhanced discount syndrome is recessive bestrophinopathies. They can also have cystoid and static changes and can have some periarcadal deposits kind of a thing. But most of the patients will have the vitaliform deposits will be more extensive as compared to this enhanced discount syndrome. There are few reports of having these deposits in the literature, but most of these patients will be again hypermetropes and more extensive vitaliform deposits. And X-linked retinoschisis, I think Dr. Neha has already described nicely, like how to differentiate ERG wise and clinically. So that is those are the few things I thought I'll add you. And enhanced Escone syndrome, the compared to any other RPs, and my experience or whatever the publications I've gone through, course remains more or less stable, so that patients can plan their career and future accordingly.
Right. Because we have this autofluorescence put up, Dr. Kaushik, what are your panel of imaging that you do for patients with dystrophies in general, if not enhanced discount?
If there is macular edema, then I'll obviously do fluorescein angiogram, because fluorescein angiogram is the thing which will differentiate fovea size from CM. In fovea size, in most of the cases, it will not show macular leakage, betaloid leakage, which is seen in CM. And I'll get OCT and fluorescein angiogram. I do not have autofluorescence, but I had autofluorescence. I will use that, and along with that, my setup doesn't have any electrophysiological testing. When the diagnosis is very obvious, I usually do not advise electrophysiological testing. But when there is a doubt, then I send to places which actually have that.
Right. Dr. Neha, so again, the same question for you. In your experience, how do you think autofluorescence has helped us in diagnosing, or at least narrowing down our differentials, especially in cases of dystrophies?
So I think I use autofluorescence very commonly. Almost every patient who gets a picture clicked also gets a autofluorescence picture clicked for me, and especially useful in dystrophies. Of course, all the vitelliform ones will just light up with an autofluorescence, and even in autosomal recessive bestrophinopathy, like Dr. Purna was saying, your FAF is quite helpful. Plus, even in RP, you get that Robson ring on autofluorescence, which is the kind of the junction of the photoreceptors which have already degenerated and which are left. So the Anthony Robson, who described it from Woodfield. So you get that Robson ring in RP patients, which is again quite typical. This pattern of autofluorescence of enhanced S cone is also typical, but they are basically it just shows the involved area where the photoreceptors have been involved and the uninvolved area. So that it will show one, and second, if there are any deposits, lipofuscin deposits, that your autofluorescence will show. And both of these things happen in dystrophies. So in a general overview, I would use it to A, diagnose, B, to also follow up, and C, also to prognosticate, because indirectly autofluorescence will give you all of this. In fact, wide field autofluorescence also does show many typical patterns. And just looking at this, I was in fact thinking that I have seen some patients of peripheral cone dystrophy where you can get a similar hyperfluorescent ring around the macula. So of course you have to go along with the clinical picture and the OCT, but FAF is definitely very important in all of our dystrophies. So about the one thing, just I mean, normally when I see an OCT like this, can you just go to the OCT once? So this is, looks more like a schisis if you look at the layers carefully rather than an edema. So maybe I would avoid doing an invasive test in such a patient. Especially once I see the autofluorescence, because that would again clarify. And then it's bilaterally symmetrical. There's a history of night blindness. So my first guess would go towards schisis only. Of course, as Dr. Kaushik said, if there is any doubt anytime, then you must do an angiography since these are non-leaking. But this doesn't look to me like a CME. This is very much a maculoschisis.
Yes. So, Dr. Purna, if you want to add something to that.
Yes, I do agree. Like, for example, angiography, I do avoid doing in these cases. Like, for example, if you take for such an extensive, see, if you want to do an angiography, means you're thinking in terms of inflammatory disease. Okay, just give me one. Sorry, there was somehow sound background noise. I thought, okay, fine. Yeah. So angiography, if you're doing, that means you're thinking in lines of inflammatory angles. So for any patients to have so much of background pigment retinal changes with this much of edema, you can't have it in quiet vitreous. You need to have some kind of vitritis, pain, other signs of inflammation. So, and also the pattern of edema, if you look at the thing, if you correlate, if you put everything together, my threshold for ordering an FFA is very high. So that is one part. So regarding the autofluorescence, I know like there may be many PGs will be watching this one. Autofluorescence basically, I mean, for me, like I can't function my dystrophy clinic without autofluorescence. Autofluorescence is a must for me. Like without, when I was in Moorfield, their consultants look at for autofluorescence even before looking into the fundus picture, ask the patient. So that is the extent to which they depend on autofluorescence. So autofluorescence basically requires a talking going on between RP and a photoreceptor. If they're talking well, they're in good terms, you get a normal autofluorescence. Whether we get hyper autofluorescence or hypo, it depends how disturbed they are. So that's the simple thing. Okay, so autofluorescence is a must for me,
Right.
or any dystrophies.
Right. So again, going on to
I have a question for this. Like in retinitis pigmentosa, the Hobson holder ring will go on contracting as the disease progresses. So in this case, if the disease progresses, so what autofluorescence do we expect? What changes in autofluorescence?
Autofluorescence just progresses. I mean, if there is atrophic changes, there are obviously autofluorescence. What if you can go back to the autofluorescence, the previous slide? So whatever the black zone, that keeps enlarging, either eccentrically towards the center. So that depends on how healthy your RP and photoreceptors and the stage of the disease. And also this Robson holder, I mean, Anthony Robson is very good friend of mine. I mean, it's not a very specific sign. I mean, most of the time we'll get it.
Yeah.
So yeah, it's not a specific sign.
so while again taking forward what Piyush asked about the autofluorescence in cases of progression. So we know that enhanced S cone is either most of the time non-progressive or extremely slowly progressive. So how different is your counseling in these patients as compared to what it would have been in the previous case that we saw? And how would you follow up these patients? Dr. Purna and then probably Dr. Neha, if you can take that.
So my follow-up schedule for these patients who are, I mean, confirmed diagnosis with enhanced discount syndrome is 6 months. Earlier, I used to do once in a year. For the imaging, I'll do once in a year. ERG once in 3 years. That's my schedule for any dystrophies. But until recently, where I saw a patient who is, 17-year-old girl, was a case of enhanced discount syndrome, developed CNVM. So from that time onwards, I usually follow up these patients once in 6 months. So sometimes children may not be able to notice that subtle change in whatever the vision, the waviness, and all that. For that reason, usually I follow them up at once in 6 months. Of course, as you rightly pointed out, it's very important to diagnose because the clinical course, most of the times, it is stable. So that's what you're going to tell the parents and all that. They can go to, most of the patient, they can go to the normal school. But of course, you need to give a letter to the principal of the school stating that so and so condition is there. Maybe they may have to make the child sit in the front bench and maybe give some extra time when during exams and all that. Because like most of these children with dystrophy, the external eyes appear normal. Most may not agree that they have actual problem. So that is important. It's your responsibility as a clinician to issue a letter most of the time. In case if the school side, if they're not getting the cooperation. And the second part is low vision needs. It depends again the vision again. Patients with enhanced Escon syndrome can have 6/6 vision also. So if the vision is less because of sometimes because of the skytic changes, if they are there for a long time, can have some atrophic changes also. You can advise low vision aids. And the rehabilitative measures I already explained. So only job I advise them not to go for is of course obviously the surgical and the things which involves greater depth like binocular vision, shooting and things like that. And contact sports, if the vision is good, it's not a contraindication, unlike any dystrophin associated mutations. So that's how I counsel my patient, my follow-up schedule.
Dr. Neha, anything else that you want to add?
Yeah, so most of the things Dr. Purna has covered. Only thing is, almost all patients with dystrophies do have a refractive error, even if they come to us in childhood and the vision is good. So just for the refractive error testing, I call them 6 monthly. Otherwise, I call them yearly in cases of adults, and the imaging also I repeat yearly. And in fact, the ERGs also I like to do yearly, at least the multifocal ERGs, because like I said, they correlate with the photoreceptors at the macula. So also for my understanding of the disease, as long as the patient understands that, I like to do the multifocal or the pattern, whichever is possible, yearly. So rehabilitation also, yes, he has mentioned quite well. Another point I like to make is that many a time, especially in slightly older patients, they come for second opinion for anti-VEGF, and I've had patients who have received Ozurdex for RP with CME, and there are also publications on this. So that I like to counsel them and explain to them why, because another practitioner might mistake it as CME and advise injections. So why they do not need that. Again, like I said, there have been publications on utility of Ozurdex in, even CME associated with RP, but frankly, I don't prefer to use. And also, I think somebody's talking about Dorzox eye drops that also I do not like to use. There are very isolated case reports, anecdotal, which we really can't rely on, which say that there is an anatomical response and no functional response or minimal functional response. So it's no point subjecting to that. In fact, I remember I had a patient of enhanced ESCON. She was a lady who somebody else had started on Iopar SR Dimox for the systemic, and she developed gallstones, and then she came to me. So a therapy which has no proven benefit, I would not like to give it to get more side effects. And another thing I think was already discussed, that these patients are usually hyperopic as opposed to RP patients, which are mostly myopic.
Right. So that was basically my last question for this particular case in general in dystrophies. How much do you rely on the symptomatology of the patient and the refraction, uh, just to aid to the diagnosis of what you are seeing on the fundus and the imaging?
It just kind of corroborates if it adds on to your story. Like if you're thinking enhanced test cone and the patient is hyperopic, you would take that as a plus point. But it's not as if it can't happen in myopes or near emetropes. So I mean, I wouldn't rely on it 100%, but it would be one of the points that I would use in the favor. But mostly I've seen, like I said, most of the dystrophies are myopic. And there would be very few which are actually hyperopic, and enhanced S cone is one of them. Even X-linked retinoschisis are more hyperopic than they are myopic. So in that way, it kind of helps.
Right. Dr. Kaushik, any closing comments from your side?
Another thing is livers. Livers is also usually patients are very highly hyperopic.
Yes.
Right, exactly.
And also, I want to add, though most of the cases, the in RP there is foveositis. Some cases can have intraocular inflammation, intermediate uveitis like picture and CME. We have already published that thing. We used to give posterior subtenon injections, and the CME would go away. But there was definite vitreous inflammation in that case, and the angiogram showed petaloid leak in that case
Right. So
with
in
retinitis pigmentosa.
cases of inflammation where there is a coexisting inflammation, probably there is plus minus the use of steroids. Dr. Poona, any closing comments from your side?
No, same thing, like more or less coming to the treatment part of it, I agree with Dr. Neha. I usually avoid giving supplements, any kind of this Dorzox, oral acetazolamide and things like that. Because even in RP patients, and Dr. Kaushik has brought out a very important point, there can be an RP CME has got multiple etiology. There can be inflammatory element also involved. Those things you should not miss. And these cases, they respond beautifully to the intravitreal Ozurdex. That's my preferred choice. I mean, of course, IVTA also I've used, works equally well. I prefer Dorzox because most of these patients are younger. For other reasons, I prefer Ozurdex. So that is one point. And regarding any other, I know like many will be listening, right? Many retina specialists. Regarding these supplements, be careful about what supplements you give. So that is one thing. The some supplements can be very detrimental. So if you go to the gene and the mutation, how it works in the visual cycle, so some of the supplements, even for the AREDS formulations also, because I see most of the dystrophies patients coming to me with nothing to offer, people just they give just some glow eye, that this and all that, but these should not be given, especially if you are suspecting an ABCA4 mutation. I personally don't prefer in any of the macular dystrophies because I don't want to overload these photoreceptors and RPEs, which are already weak. They are not able to digest this whatever the extra you're giving, and these will all get converted into toxic byproducts. Better stop giving them. Rehabilitative part of it we have already covered. I mean, it can be a separate topic in itself, how to rehabilitate this dystrophy patient, genetic counseling and all that. So that is thing. And when the follow-up is very important. So like that. And the follow-up, you have to tell them, show them the progression. Autofluorescence really helps. If the parents are educated enough, you can show them what are the changes and reassure them. And the most important thing is what we ignore is the psychological aspect of it. Speak to them, and if not for the patient, the closest one. Of course, these are genetic problem. Again, you can't reveal to many. I mean, again, they might sue you. Like you can reveal with the patient consent to anyone. Ask them, are there any tendencies? Some patients really help if you refer them to the psychiatrist if they're not able to adjust. I have seen patients who was advanced RP with 3 by 60 were very happy roaming independently, very well adapted. I have patients of 6 and 6 RP, but depressed like anything because they have been counseled. They have been told like you have something in eye, which for which there is no treatment and all. Even patients of achromatopsia, which is stationary, they've been told you may go blind and all that. So of course, people play safe, but that's not the right way. Basically, you need to counsel and just tell them in next 1 year, don't worry. After 1 year, when you repeat the scan, that time we'll discuss about the progression. So that's all. That will kind of reassure them. And always, as far as possible, let them be in the regular school. So before shifting to the blindness, you are the clinician, you have to decide. You have to discuss with your visual rehabilitation specialist before you shift them to the special schools. So that's what I wanted to add and brief,
Right.
whatever.
I guess that was the perfect, closing comments to dystrophy session. I guess most underestimated point in managing dystrophies is the counseling and the way we talk to our parents, the way we talk to our patients and their close relatives. So I would thank all the three
Dr. Komal, I just wanted to add, because these patients are like they are already their vision is so low, and I usually give in phobiasis, I usually give dorzolamide drops, because it will not harm, and if you are giving him some hope, and I have seen things, the phobiasis actually can reduce the central macular thickness, can reduce and also can become normal also. So this is obviously a personal experience, and I do not have a large series, but I usually use dorzolamide topically for such cases with phobiasis.
Right. I would like to thank all the three panelists, Dr. Neha, Dr. Puna, and Dr. Kaushik, for taking out the time, such late at night, and coming up with such important comments on our two cases. Not to mention our two presenters, Samiksha and Piyush. Thank you so much for bringing out those interesting cases. So I think we'll close here now. And thank you very much, everyone who had joined us for this session. Thank you.
Thank you.
Thank you.
Thank you.